Hi everyone, my name is Lauryn Silva. I am a P2,
Hi guys, my name's Miranda Morman and I'm a P1.
Hi, my name is Kaylee Morosky, and I'm also a P1.
and we are doing our presentation on the effect of the opioid epidemic for underserved communities. So we're going to start with an overview of opioids. So we'll start by talking about what an opioid actually is. An opioid is naturally found in the opium poppy plant, but it can also be made chemically, which you can also hear some people say that it's made synthetically. Initially, they were used to treat wounded soldiers in the 1860s, but nowadays they are a chemical and a medicine that we use to treat pain or to cause sleep, depending on the circumstances. And the reason that we're talking about them today is because of their addiction potential. They are highly addictive. So here I just listed some examples of opioids. So you can see their structures on the right. Some common examples are fentanyl, oxycodone, hydrocodone, codeine, and morphine. And then just a fun fact, heroin is also an opioid, but it does not have any medical benefits, so it is banned by the federal government. So on this slide, I just talked a little bit about the effects of opioids. I decided not to go very deep into the science just because it can get a little bit messy. On the left, we have a word description. On the right, you can see a visual description of what goes on. So the main effect of an opioid is pain control. Its main purpose is simply to block pain signals between the brain and the body. As a result of this, many people can feel relaxation and a euphoric feeling. And the relaxation and euphoric feelings are what propel people to become addicted and to overuse them. So on the right, we can see that in the normal brain, the opioid receptor is somewhat stimulated, and it just causes normal stimulation for the dopamine reward system, meaning that we have endorphins land on our receptors, we feel relaxed, we feel happy, things of that nature. And then when we are using opioids, we get excessive stimulation, which causes the relaxation and the euphoric feeling. But as we will see on the next slide, those also have some pretty major side effects. As I mentioned, some of the side effects of an opioid are slowed breathing rate, nausea, confusion, sleepiness, and constipation. One of the main reasons that people die from opioid abuse is because they take so many opioids that they actually slow down breathing and eventually can stop breathing completely, which is why many times we find these patients completely unconscious. And on the right are some more side effects that occur when you use opioids, but the most common ones are on the left. Now, after we talked about all of that, you may be wondering why they're even used anyway. So again, typically they're used for pain control. Many times they'll be used for chronic pain. Sometimes they'll be used for post-operative pain. I know that when I personally got my wisdom teeth out, I was given oxycodone. If someone is undergoing cancer treatment, they will often get opioids to try to ease the pain. It's also used for palliative care and end-of-life care to help make these patients comfortable with their conditions worsening at the rate that they are. So now we'll give a little bit of backstory of how we got to where we are with the opioid epidemic. So this slide shows the stats. In 2020, there were 1,378 overdose deaths in Connecticut. In 2020, there were almost 92,000 overdose deaths in the USA.
So how did it get here? Well, by the 1990s, patients and providers were assured that the opioids were not addictive. The big pharma that were giving out the opioids were telling prescribers that they should be given for all pain because they're super effective and non-addictive. Because of this, providers decided that, okay, then we will. So the rate of opioid use began to rise rapidly. This also led to a rapid increase in misuse and overprescribing, which ultimately led to many addiction issues and many overdoses. Since 1999, opioid overdose deaths have quadrupled. Even when the big pharma was told that opioids were addictive and were going to be problematic, they still worked to assure providers that it was okay, and ultimately, the benefit was greater than the harm. So what happened after that? Well, in 2010, the rates of heroin overdose rose exponentially, and this has been considered to be due to the continued overuse of opioids. Many people also mention that heroin is cheaper than getting the prescription opioids, and you also don't have to go to a provider, so its ease of access may be a little bit better, and this has caused many problems with people overusing it, especially because when you continually use opioids, it causes your body to become used to that amount, which makes you want to take more and more to get the same feeling. So I just wanted to put these articles to bring it back to home. Not that long ago.
January and February, there were 3 cases in school systems in Connecticut where students almost died or did die from exposure to fentanyl. For those who may not know, fentanyl is deathly at a very tiny dosage. So the left one talks about a 16-year-old student at Bloomfield High School who luckily did survive, but had to be given many, many doses of Narcan in order to survive after smoking some marijuana that was laced. And then on January 15th, another teenager actually died from being exposed to fentanyl. And then the story in the middle on the bottom talks about that 13-year-old's death and how schools are going to address overdose potential in the future.
All right, now we're going to talk about how the opioid epidemic has affected the underserved communities. So the opioid epidemic is affecting the entire country. However, it has been found that typically young, unmarried people who lack health insurance or those who have lower incomes are disproportionately affected by the opioid epidemic. And these people often live in rural, frontier, or underserved communities where there's limited health and social service infrastructures. So on the left, this graphic shows um, the number of prescriptions for opioid painkillers per 100 people throughout the United States. And you can see the purple area is where there's a very high amount being prescribed. And you can see much of it includes the Midwest and the Southeast. These are typically more rural areas as opposed to like the Northeast with more cities where people living closer together. And then on the right, this graphic shows the number of states with medically underserved areas, as shown through the number of primary care shortages. And a lot of the same areas, such as the Midwest and the Southeast, that have a lot of prescription painkillers, also have shortages of primary care physicians. And this could be due to the fact that the doctors in these areas, since there's a shortage, they don't have adequate time to see every patient. So when a patient complains of having pain, they are more likely to just prescribe an opioid, since, like Lauryn mentioned before, Big Pharma promised that they didn't have any addictive properties when it has been shown that they actually do. So like I said, people who live in rural or frontier communities have been more disproportionately affected. A CDC report from 2015 found that the overdose rate for rural areas surpassed the death rate for urban or suburban areas. And then another report also found from 1999 to 2015, the opioid death rates in rural areas quadrupled among 18 to 25-year-olds and tripled specifically for females. And then another report also found that the rate of neonatal abstinence syndrome, commonly referred to as NAS, which is a group of conditions that's caused when a baby withdraws from certain drugs that they've been exposed to in the womb before birth from the mother taking opioids. So this condition has risen twice as fast in rural areas as opposed to urban areas. All right. And then another group that is disproportionately affected is the Black or African American communities. So for African Americans, they are 29% less likely to be prescribed opioids for pain as compared to white patients. This could be due to a miscommunication about pain with their medical provider. And then there's also been a history of use of illicit opioids, such as heroin and cocaine, opioids that are not provided through prescriptions in low income African American communities. And this dates back to the drug epidemics of the 60s and 70s. And as Lauryn mentioned before, these drugs have been increasingly laced with fentanyl, leading to more opioid-related deaths. All right, I just want to put in this graphic, which shows the increase of drug overdose deaths in Black African Americans involving all types of opioids. This was taken over a 3-year span from 2014 to 2017, and you can see for each type of opioid, there was more than 100% increase in death rates. So the numbers have skyrocketed in only a 3-year time span. And this was still done 5 years ago. So I'm sure if you look at the numbers today, they would be much higher, unfortunately. So some of the reasons that people in these underserved populations are suffering more compared to others are for a multitude of reasons, one of which is accessibility. So for people who have lower income or in rural areas, it might be harder to access medical centers. This could be due to a lack of transportation. Not everyone has their own car, and they might have to rely on public transportation, which may not stop at a medical center or a place where they can receive medical services. And also, especially with rural areas, it might be too far for people to travel. Sometimes the nearest hospital might not be for another like 30 or 45 minutes away, which in that case, it can be hard to receive the medical services that you need. Another reason could be availability. So even if people are able to access and get to medical centers, it doesn't mean that these medical centers provide the adequate care that they need, especially when it comes to opioid treatment. So especially in these rural underserved communities, there's a lack of trained healthcare professionals who can help treat people with opioid use disorders. Another reason is the stigma regarding opioid use. So like I mentioned before, treatment in rural areas for opioid use is usually scarce. So if someone actively is seeking treatment, there's usually a lack of anonymity, which may scare people into going to seek it because other people will know that they are facing this problem and they might not want other people to know there's having this issue. Fortunately, much has been done today to reduce the stigma surrounding opioid use, such as changing the language, as shown with the graphic on the right. But with many other things in society, it usually takes longer for these types of things to reach rural communities as opposed to the densely populated urban areas. Another reason includes inadequate funding. So especially rural, underserved communities may lack the funds to pay for having these treatment services for opioid use disorders. So usually the medical professionals who run these opioid treatment services may be too expensive for these communities to afford to pay, or the patients themselves might be unable to pay for such treatment services due to lower income or lack of health insurance. Another reason could be the institutional bias against MAT, which is medication assisted treatment. So some people believe that in order to overcome an addiction, you have to be free from any medication or any kind of substance. And we'll go over some more examples of these other medication assisted treatments shortly. And then one more reason as a barrier is unequal treatment. So unfortunately, sometimes depending on race, income, geography, or insurance, medical providers provide different kinds of treatment in the United States, which could prevent people from getting the treatment services they need. So now we're going to talk a little bit about some alternatives for pain treatment instead of opioids. So like I just mentioned before, there's opioid dependency medications that are usually used to treat opioid use disorders. These MAT medications are safe to use for months, years, or even a lifetime. So these include methadone, as shown on the left, buprenorphine in the middle, and naltrexone on the right. So I just wanted to briefly mention there is a difference between opioid dependence and having an addiction to opioids. So opioid dependence is when the body has a physical dependence on opioids and requires a specific dose of a particular opioid in order to prevent withdrawal symptoms. And usually this occurs when a patient is taking an opioid for a long period of time, usually 6 months or longer, to manage pain associated with a medical condition. On the other hand, opioid addiction, also referred to as substance use disorder, is abnormal and it's actually defined by the DSM-52 as a chronic treatable illness. So substance use disorder results in compulsive behaviors that manifest as cravings, an inability to control use, and continued use of the drug despite its harmful consequences. And it can occur separately from the physical dependence, although most commonly it's also seen with being physically dependent on the drug, on the opioid. So, and the patient usually takes this to accommodate the brain's reward center and that feeling of euphoria that comes when taking opioids, like Lauren mentioned in the beginning of the presentation. Luckily, there is a medication that can be used when a patient is going through an opioid overdose. This is called naloxone, or more commonly known as Narcan, and it's used to prevent opioid overdoses by reversing the toxic effects of an overdose. This is a life-saving medication. If someone is having an overdose on opioids, if you can administer naloxone in time, it can very well save someone's life. And usually this can be purchased at a pharmacy without a prescription in some states. Connecticut is one of those states where you can purchase Narcan or naloxone from a pharmacy without requiring a prescription. And pharmacists, as I mentioned, can dispense naloxone, but they can also, in Connecticut, if the pharmacist does take a short training, they will actually be able to prescribe naloxone to patients and caregivers. And that allows the pharmacist to have more responsibility and provide the product to the patient and give them useful information and training on how to use naloxone in the case of an opioid overdose. As far as treating the pain, there are some other non-opioid pain medications that can be prescribed, including NSAIDs, or non-steroidal anti-inflammatory. Oh my God, I just forgot it. We'll cut that out. But so that you can, for pain, you can take NSAIDs, which commonly is seen in the stores as ibuprofen or naproxen. You could take acetaminophen, more commonly known as Tylenol. You can get glucocorticoid steroids. The doctor can prescribe beta blockers, anticonvulsants, or also antidepressants, depending on what kind of pain the patient is experiencing. Some alternative therapies include not taking any medications at all, so such as holistic pain management. Things like acupuncture, yoga, massage, or exercise all have been shown to reduce pain, as well as having the patient go through physical therapy. Depending on what kind of pain it is, they can be a good candidate to receive physical therapy to help manage their pain.
Okay, so now we're going to go into some current efforts to overcome the opioid epidemic. So efforts to stop the opioid epidemic vary from different countries, but access to medication-assisted treatment, or MAT, is at the center of policy response. In November 2016, the US Congress voted to fund former President Obama's $1 billion Comprehensive Addiction and Recovery Act, or CARA. This proposal to address the opioid crisis focuses on increased access to MAT in the form of methadone, buprenorphine, and injectable naltrexone, which were all talked about by Kaylee and Lauryn. Also, it wants to target funding to states that are most affected by the opioid epidemic, and it had innovative plans to address treatment disparities. Additionally, one of the objectives of Healthy People 2030 is to reduce the proportion of people who had opioid use disorder in the past year. Opioid overdose deaths have risen sharply in recent years, and reducing opioid use disorder is key to preventing overdose deaths. Improving opioid prescribing practices and increasing access to and use of medications for addiction treatment can help reduce opioid disorder. So Healthy People 2030 is using the baseline data of 0.7% of persons aged 12 years and over reported an opioid use disorder in the past 12 months in 2018. The goal is to reduce this number to 0.5% by 2030. There are many challenges in responding to the opioid misuse prevention and treatment, so I'm going to go into some of these challenges and kind of what's being done to try and overcome them. So the first challenge is prescribing practices. Pharmaceutical advertising and prescription practices have contributed to the current opioid epidemic, and opioid prescribing practices have become a high-profile issue in the U.S. Prescribing guidelines from the CDC emphasize that opioid prescriptions are to generally be avoided for chronic non-cancer pain, and that if an opioid is deemed necessary, providers should start at a low dose and increase doses very slowly. While this is an excellent starting point, it is also likely that providers will take many years to fully adapt to the new guidelines, and that additional training in pain management and addiction medicine is required. The next challenge is MAT infrastructure and cost. While MAT is at the center of policy response to the opioid crisis, there is inadequate infrastructure for MAT delivery, and a treatment gap exists, with more than 1 million eligible opioid-dependent individuals not receiving care. In the U.S., new MAT treatments are often not covered by insurance, and part of the treatment gap is likely attributable to the lack of a national healthcare system. I will talk a little bit more about this on the next slide. The next challenge is provider-level factors. So physicians have been characterized as having low confidence in addressing addiction, limited access to addiction experts, lack of institutional or office support, lack of behavioral health services, and reimbursement concerns. This is related to the fact that physicians receive little addiction training. In fact, the lack of experience with addiction treatment in the U.S. is thought to be a primary barrier to buprenorphine prescribing in the U.S. The Substance Abuse and Mental Health Services Administration of 2017 expanded MAT availability by allowing previously trained nurse practitioners and physician assistants to prescribe MAT in the form of buprenorphine, but has faced implementation issues as only 2.2% of physicians are waived to provide buprenorphine. The next challenge is policy factors. There remains ongoing stigma in the U.S. against opioid treatment programs, which has resulted in numerous state and local level policy barriers to care. However, this is becoming a larger federal issue, so hopefully states continue to follow suit. And lastly, the last challenge I'm going to talk about is law enforcement related factors. So street-level drug marketing policing remains a key barrier to addiction treatment access among marginalized drug-using populations. The U.S. has harsh illegal drug policies that are likely contributing to the high levels of illegal drug use, and it has been suggested that a focus on supply-side drug market interventions in the U.S. has not meaningfully impacted the availability of illegal drugs. But emerging public health and policing partnerships, including police diversion of persons who inject drugs to medically supervised injection facilities, suggest a potential role for police in improving the engagement of individuals with opioid use disorder in appropriate care. As I touched upon a little bit in the last slide, there's an MAT treatment gap in the U.S. The U.S. is lacking in low-threshold programs, which increase treatment accessibility for the greatest number of individuals in need. Low-threshold models might involve free or low-cost therapy, shortened waiting lines, and integrated care centers that provide mental health services. Such models are becoming the standard of care in countries such as Canada and elsewhere. In the U.S., there have been successful examples of low-threshold programs, such as the San Francisco Department of Public Health's office-based buprenorphine pilot program aimed at integrating buprenorphine treatment into the outpatient setting, as well as the office-based buprenorphine model piloted through community health centers in Massachusetts. However, these programs are rare and often remain in the pilot stages. Additionally, there are also significant disparities in access to MAT by race, as white patients tend to receive buprenorphine, while Black and Latino patients are more likely to receive methadone. Now, I'm going to talk a little bit more about disparities in opioid treatment. So not only is opioid treatment lacking all around the country, there are disparities in treatment that are adding to the issue. This is highlighted by a Recovery Research Institute's study of metropolitan areas which found racial disparities in treatment completion. The study aimed to address the fact that although 90% of those who tried heroin for the first time the last decade were white, the largest increase in opioid-involved deaths were among individuals who identify as Black. Since treatment completion is associated with a better prognosis, the study sought to determine if there are racial and ethnic disparities in treatment completion for patients reporting opioids as their primary substance. This study used data from the 2013 TEDS-D, which is Treatment Episode Dataset Discharges, which is a national survey of mostly publicly funded treatment programs. The variable of interest was race and ethnicity, with categories that included non-Hispanic white, non-Hispanic Black, Hispanic, Asian, and other race or ethnicity. This variable was examined in relation to treatment completion, defined as all parts of the treatment plan or program were completed, and where non-completion included the designations of left against professional advice and terminated by the facility. So this is the graph from the study that shows the percentages of treatment completion. And the study concluded that treatment completion for primary opioid use varied significantly by race and ethnicity, with white patients having the highest completion rate of 29% and Black patients having the lowest of 21%, and Hispanic individuals were closer to whites with 27%. So the study also found some other factors associated with lower odds of treatment completion, and these included homelessness and using more than one substance. And it also found some factors associated with greater treatment completion, and these included being over the age of 50, having 12 or more years of education, full-time employment, attended residential treatment, referred by the criminal justice system, other drug or alcohol treatment providers, and referred by one's employer. Lastly, we're going to talk about the future directions of opioid treatment and ending the epidemic, and the goal is to focus a public health-oriented treatment system. So, while many challenges exist in developing an effective treatment system for opioid use disorder, using a public health-oriented approach is key to bridge the treatment gap and control the opioid epidemic. So I'm going to go through a couple changes that will really increase the treatment and getting to where we want to be in a little more detail. First, federal and state level funding for MAT treatment centers must be increased to address the 92% of opioid-dependent individuals eligible for MAT treatment. This will require building on momentum from the funding of former President Obama's $1 billion proposal. Second, barriers that inhibit clinicians to prescribe MAT must be removed. In other countries, such as France, all physicians can prescribe buprenorphine without any waiver limits. If the U.S. follows suit and MAT can be provided in physicians' offices, patients could have easier access to treatment. Additionally, in Canada, MAT dispensation is available through pharmacies. Adopting a similar policy would dramatically increase treatment capacity in the U.S. And lastly, it is essential that physicians receive greater addiction training during their medical school and residency years. Third, geographic hotspots of opioid misuse among marginalized populations should be prioritized for the provision of low threshold and experimental approaches to MAT delivery. A truly national low threshold model for MAT in the US likely requires a further expansion of access to healthcare among marginalized populations to ensure access to the best treatments for opioid use disorder. Fourth, there must be an overall shift towards more harm reduction oriented policing practices. In the US, there have been recent legislative shifts towards less harsh policing, with the former President Obama's bill expanding access to naloxone. The implementation in the Washington state of Good Samaritan laws aimed at empowering community members to prevent overdose. In California's Proposition 47 sentencing reform, which in 2014 reclassified personal drug possession and use as a misdemeanor rather than a felony. And finally, pharmaceutical companies and academic research institutions should be further engaged in developing novel pharmacotherapies for opioid use disorder, accessible to a large range of populations. And then these are our citations.